And there we go. So this is this week. And so these two mini lectures that we're going to do this week are all about joints. And my word of advice right off the bat is this stuff, the joint business, it really isn't rocket science. It's not, nobody in this course doesn't have the ability to really understand this. The difficulty is organization and language. So I'm going to try my best whenever possible to help you with organization and language. So when I look at this chapter, even as the instructor, it gets kind of lost or bewildering. I wish they would have done more of an organizational feat of strength with organizing this chapter, but they didn't. So it is what it is. Let me try to help you with that. I'm going to go right to my first whiteboard and start talking about joints. And when I do this, I want you to think of always think of two things when you think of joints, structure and function. So, and we classify joints based on those two categories. So everything that's in this chapter, as well as everything pretty much that I say and talk about, will be surrounding those two topics: the structure, meaning what it's made of, what it looks like, and how it moves, its function. So the first thing after I write just joints for a header is I want to talk about the classification of function of joints. Functionally, we classify joints into three main categories. This is important. We'll refer back to this classification often. So functional classification, there are three main classes of joints. The first one is called SYN, S-Y-N, arthroses. Arthroses means joint, or the word arthro technically means joint. Like there's a whole class of insects called arthropods that literally translates to jointed foot. So this, whenever you see the word arthritis is inflammation of a joint, that just means joint. Nevertheless, SYN arthroses, one word, always think of immovable. So this is a joint that doesn't move. SYN arthroses are immovable joints. Second classification, functionally, is amphi, A-M-P-H-I, amphiarthroses. These are slightly movable joints. Now, one thing your book I don't think addresses with this classification, this is a fairly wide range of movement. So some amphiarthrotic joints barely move at all. Others move more within that classification, that category. Last one, number 3, are diarthroses. These are fully movable. They're what you and I mostly think of when we hear the word joint, because those are the things that we see move and that we move by conscious control every day. So these words can also be used as adjectives. So like I can say a certain joint is synarthrotic. That means it's immovable, or amphiarthrotic, or diarthrotic. So if it ends in TIC, that's just a derivation of these words used as an adjective. All right, so that gets this out of the way, and that was fairly simple and fairly easy. Now, when we go forward, we're going to talk about all sorts of different joint types in the human body, and we're going to use these functional classifications as we talk about their structure. So we're going to identify what the rest of this chapter is about, is identifying joints mostly based on structure. And then we say that particular joint based on structure is either synarthrotic, amphiarthrotic, or diarthrotic, based on how fully it moves or if it doesn't move much at all. So let's get on with it. Now I'm going to go to structural classifications. This is where the organization gets slightly more challenging, but I will try to help you. Structural classifications, just think this is the type of tissue, what it looks like, and the type of tissue that it's made of. And I'm going to go in the order of your book. I have an old copy of the textbook in front of me, and I'm just going to list them in the same order and talk about each one. So the first major group within this structural classification, I'm going to label this big number 1, fibrous joints. These are, it's a class of joints, structural classification of joints, where there is no cavity present, no joint cavity, and the bones are held together, or what binds the bones together is dense irregular connective tissue. I'm just going to write dense irregular CT is what binds the bones. Now, this dense irregular CT is often in the form, sometimes in the form of ligaments. So there's dense regular connective tissue as well. Technically, there's both dense irregular and dense regular. So, but this describes it, no cavity, and there's thick fibrous dense connective tissue that connects the bones together. Now, there are sub-specific joint types within fibrous joints. This is where the challenge comes in. So I'm going to use lowercase letters to then classify within fibrous joint classification are, and I'll go in the order of your book, first, sutures. We know what a suture is now because we've already studied the skeletal system. It's a joint, I'm going to write only in the skull. We only find these in the skull. There are those tight, interlocking, immovable joints in the skull that the cranial plates form when they finally fuse. So it's a very short distance of fibrous connective tissue. Think dense regular, dense irregular, fibrous connective tissue that produces, I'm just going to use this because it's up here. Remember this word, synarthroses, immovable. So these joints are, we say, synarthrotic. I'm going to take that with a grain of salt for a moment. So they're immovable. I'll write that out just to remind you. I'm not going to do this every time. Here's the deal about sutures. They are synarthrotic in an adult like you and me, but in a young child, an infant and a young child, they're actually amphiarthrotic. Remember those fontanelles? So those sutures, I'm just drawing 2 parietal fontanelles here. Those sutures are not fully fused at birth. So in an infant and in a young child, well, a suture is technically the fused version. An amphiarthrotic beginning then becomes synarthrotic when it's fully fused. So I did want to call your attention to that. If I ask you a quiz question coming up, for example, a suture in an infant, a newborn, is A, synarthrotic, or B, amphiarthrotic, the correct choice for that question would be B, amphiarthrotic. They're slightly movable in the young child. But then after they fuse, after a few years after birth, they become synarthrotic, immovable. There is one last thing before I leave sutures. This word in your book, and it's important to know, synostoses. I know all these words look and sound the same, and they almost mean the same thing. Synostoses is slightly different. This means 2 completely fused sutures. So remember in the cranial plates of the skull, we have sutures between the parietal bones, occipital bone, temporal bone, frontal bone, those easily seen sutures. That's actually this joint that looks like this that we can see. Microscopically, what's going on at that joint, I'm going to exaggerate it, is something like this. And there's really, it's very short. I've exaggerated this space, but there are tight fibrous connective fibers between those two bones. That's what a suture looks like if magnified a gazillion times. A synostosis, there is no seam anymore. The bones are completely fused and there's no, I'm running out of white space here. There's no sutures left in a synostosis. It means complete fusion of two bones is really what it means. Examples of that would be things like the frontal bone itself or the three bones in the pelvis, the hip. We can't see any lines. There's no evidence. There's no squiggly line like a suture in the skull. It just looks like one giant bone. Technically, that's a synostosis, where a completely fused bone, even past a sutural remnant. All right, let's move on to the next one. So I'm still in this classification here. I'll highlight it with red. I'm still talking about fibrous joints. I'm just going to move on to the next whiteboard and go to lowercase b. We've done sutures. So lowercase b. So we're still talking about a type of fibrous joint, a syndesmosis. This is what I meant by the language. It all sounds the same. This is a fibrous joint. So I'll remind you, it's fibrous. There's no joint cavity, but the fibers, so I'm trying to put a semicolon here. Fibers tend to be a bit longer than in a suture. So we still have two ligaments tying, or we have ligaments tying two bones together, but the fibers are longer, and it's going to give opportunity for a little bit more movement. So there's still, I'll remind you, there's still no joint cavity present. And classic example of this syndesmosis would be, I'm going to draw the femur. Sorry, let's do the radius and the ulna. It's a little bit easier for me to draw. There's the head of the radius. We'll do the radial tuberosity. It gets wider as it comes down toward the wrist. So this is the radius. And then the ulna, remember, it's that C-shaped, claw-shaped bone like this. This is in our forearm, just to remind you. There's the radius and the ulna in the forearm. There is a syndesmosis connecting these two bones together here at the proximal elbow end and down here at the distal wrist end. So it's still just a fibrous, thick, fibrous, dense connective tissue joint, but the fibers are longer than in a suture. That provides for a little bit of movement. So we call these amphiarthrotic, which means slightly movable. And you know that, well, I don't know if you know this, but when you rotate your forearm, the radius actually crosses over the ulna and it makes almost an X like variation. So we've got fibrous joints. I'm going to put a letter C down here right below my picture. Let's save that for you and write the word gomphosis. This is just a peg and socket joint. Think of your teeth. It's similar to a syndesmosis. I think technically it's a type of syndesmosis joint, but gomphosis has its own subcategory, peg and socket. Just think of our teeth. And here's what's going on in that case. Our teeth, I'm just going to draw a tooth. with its root, and that root, as you know, is embedded in bone. If this were, say, the mandible, the lower jaw, there's the socket. There, it's a fibrous joint, actually, right here, holding these teeth in. It's very tight and immovable. So this would be synarthrotic, which means immovable. Obviously, if enough force is put on that, it can break loose, but that's just from trauma and causes damage of the tissue altogether. It's not designed movement. So that covers sutures, syndesmoses, and gomphoses. Before I leave, some books categorize this stuff a little bit differently than others, and I just got done lecturing to a different class at a different university where this was its own classification, but this interosseous membrane between the radius and all of this sheet-like membrane is also considered syndesmoses by your book. All right, I'm just going to review with you. So let's go back to page 1. We've already identified 3 functional classifications: immovable, slightly movable, fully movable. That should have an S at the end of it. Now we're still studying structural classifications, and we finished 3 types of fibrous joints: sutures, syndesmoses, which just means a little bit longer fibers, and finally gomphoses, which is a peg and socket with our teeth, short fibers again. Now let's move on to just trying to help you organize this. We've done fibrous joints, so I'm going to write a big number 2 and circle it. Structurally, our next classification is going to be cartilaginous joints. Sorry, that should be a number 2. So we've done fibrous joints. Now I'm putting a big number 2, cartilaginous joints. These also, there's no joint cavity in these, but the tissue binding bone to bone, guess what? It's cartilage from its name. So I'm just going to write cartilage joins. You could say binds bones together. So rather than a dense fibrous connective tissue, it's cartilage that's going to join the bones together. And there's 2 major types of cartilaginous joints. So I'm going to write a lowercase a. And the first one is a synchondroses. Chondro means cartilage. So synchondroses. These are joints where the bones are bound together by hyaline cartilage. And I'm going to underline hyaline cartilage. So we have almost like a cartilage plate. So the classic example of a synchondroses is going to be the epiphyseal growth plate in young people. That's technically considered a joint. Epiphyseal plate is just this plate of hyaline cartilage, and then it finally fuses after growth finishes late in puberty, and it becomes a synostosis type of joint, bone on bone, with no more cartilage between there. This synchondroses are considered synarthrotic. That means immovable. Another classic example of this would be the costal cartilage of ribs to the sternum. So I'll just do one more example. that costal cartilage connecting ribs 1 through 10 to the sternum. All right, so we're still talking about cartilaginous joints. There's just one more type. Synchondroses, think this, hyaline cartilage. Second type is a symphysis. And we addressed that word a little bit with pubic symphysis in the last chapter. This is fibrocartilage, binding the bones together, not hyaline cartilage. So it's still a cartilaginous joint. There's no joint cavity. And the type of cartilage joining the two bones is fibrocartilage. Classic examples, I'll try to squeeze this in on this page, would be the pubic symphysis. The pubic symphysis, remember, is a fibrocartilage pad or disc connecting the anterior part of the pelvis, the right and left pubic bones together. These are considered amphiarthrotic, slightly movable. There are other examples of symphysis-like joints in the human body. They all occur right along the midline of the body. For example, intervertebral discs are very much like the pubic symphysis. The reason we don't call them a symphysis is they're not just joining two things, they're actually pads between each vertebrae. Also, the joint between the manubrium and the body of the sternum. Just giving you some more examples of this fibrocartilage type of joint. Remember, the sternum has a manubrium, a heart-shaped bone at the top like this, and it joins to the body of the sternum, which joins to the xiphoid process down here. These joints here are fibrocartilage as well. All right, we've done synchondroses and symphyses. That takes care of cartilaginous joints. And now the third type, structural type of joints, number 3, are synovial joints. This is what you and I think of when we hear the word joints. Structural classification, synovial joints. What this means is that they have a fluid-filled joint cavity. Fluid-filled joint cavity. And they are all diarthrotic. That means they're all fully movable. And there's lots of them, and there's lots of subcategories and classifications. So the first thing I'm going to do is show you a general makeup of a synovial cavity. So I'm going to draw just a generic, I'll be more specific. Let's just say this is the distal end of the femur, or the condyles. I'm going to exaggerate this space. And I'm going to put the head of the tibia, the lower leg bone here, below it. And I'm going to show you the components, the structural elements of a synovial joint. I'll try to use light colors that are in similar colors that are in your book. First, each bone has a thin layer of articular cartilage. This is consistent with all synovial joints. So what's in blue is a thin layer of hyaline cartilage called articular cartilage. Nice, smooth, glassy surface for these joints to work upon. Then there is a double-walled, a double-layered membrane that sort of encloses this joint. So I'm going to draw that in green. And this inner membrane layer in this area, it fuses with practically with the articular cartilage in this area. And then there's an outer layer to this membrane as well. It's double thickness. And we call this then, what's inside of it, the joint cavity. Like I said up here, it's fluid filled. Let's label some of this stuff. So this, what's in blue, is articular cartilage. Remember, that's hyaline cartilage tissue. It's always part of a synovial joint. This is a, I'm just going to put, oops, I wanted to have green, not blue. This is a double-walled membrane, 2-layer membrane making up that joint cavity. Then exterior to that, there is a fibrous layer. Just looking for a different color, I'll use yellow. There's sort of a fibrous layer of tissue that actually acts like an extension of the periosteum that is covering these two bones. So I'm going to extend this fibrous layer. So the periosteum basically just comes down, helps encase this joint. And finally, last but not least, I'll use black for this one because I'm out of colors. Now I can use red. There are ligaments, thick, heavy, fibrous ligaments that help tie this whole thing together. So that's how sophisticated this synovial joint is. I'm going to highlight some characteristics about the fluid that is found. Where this fluid comes from that's in the center, I'll put a star. So we find synovial fluid in this space. It is secreted by cells in this membrane layer, the inner membrane, as well as it comes from blood plasma that leaks out of the capillaries. So this area is very rich in blood vessels. I'm drawing these little capillaries going in. And capillaries even make their way into this space. So the derivation of this fluid is from membrane cells and capillary fluid, aka blood plasma. Synovial fluid, the characteristics of it, I'm not going to write this out for you, but it gets its name because it strongly resembles an uncooked egg white, a chicken egg white. So when you crack an egg and you see that sort of off-white or clear, almost clear, but amber colored, very viscous, sort of thick and runny material, that's what synovial fluid resembles very closely. And synovial actually means egg. Part of that word means egg. So it gets its name because it looks like the fluid in an egg. It's viscous. Its function is to really, it lubricates the joint and reduces friction. So this fluid, if the joint hasn't been moved for a while, the fluid actually gets thicker. So it's at its thickest. If we're active every day, it's at the fluid in our joints, synovial joints, is at its thickest early in the morning, right when we wake up. And then once the joints are moved quite a bit for a while, that fluid, technically it thins out. And also the articular cartilage, it actually soaks up or sort of stores some of the fluid. So this articular cartilage, its main purpose is to provide a smooth surface for bone-to-bone articulation, but it also soaks up fluid almost like a sponge. And when the joints move, the fluid moves in and out of that sponge-like material, that cartilage, to help lubricate that joint. Okay. These, I'm going to use red now. These red things that I've drawn here are called reinforcing ligaments. That's tough, dense, fibrous, connective tissue that's full of collagen, and it's just for stability, to stabilize the joint. The trade-off with synovial joints is, the great thing is that they're really movable, allowing us, our appendages, to do all sorts of things. The trade-off is they're less stable than fibrous joints. Your book describes nerves and blood vessels. Just the only thing that I want you to remember is these synovial joints are highly innervated and vascularized. That just means they have lots of nerves and vessels. There's different types of receptors. There's pain receptors in here. There's also proprioceptors, which are joint position receptors. So highly innervated and vascularized. Fibrous joints are not quite as vascularized. There's also fatty pads between the fibrous layer and the synovial membrane. So we can get adipose tissue sort of lining this joint. I'm just going to label that a fatty pad. That helps with shock absorption, which this fluid does too. So a fatty pad would also help with shock absorption. And finally, some synovial joints, not all, have some sort of a disc inside of them to help with articulation, shock absorption, distribution of weight, distribution of fluid. The knee in particular has what's called a meniscus. So let me go to a new page here. And I'm just going to write meniscus. This is also referred to as an articular disc. Example in the knee joint. This is, I'm going to quickly draw I'm not going to draw that joint all over again and all of the constituents of it. But the meniscus is a mostly fibrocartilage pad. It's not perfectly flat like a pancake. It takes on a certain shape to help our knees twist and lubricate. So what it does is it extends, it can extend slightly past the edges of this joint, which gives more surface area to absorb shock, as well as distribute fluid and create new movements. All right, temporarily we are off of synovial joints. I'm going to talk about accessories to let me get black. I don't want to waste this whiteboard. Technically, this is one. The meniscus is sort of an accessory to the joint because it's not found in all synovial joints. These are more common. You've heard of bursa, or bursae is plural. These are fluid-filled sacs associated with That means close to, around the area of synovial joints. Oops, trying to spell too fast gets me into trouble. So in my knee example here, there are bursa, little fluid-filled sacs. They're technically not considered part of the synovial joint itself. They're filled with a fluid that's very similar to synovial fluid. There are also things called tendon sheaths. Which are basically elongated bursa, tube-like bursa. I haven't drawn this, so on my last picture of this synovial joint, that's the joint proper itself that I've drawn. But as you probably know, around these fully movable joints are tons of muscles and tendons originating and inserting in bone tissue. And they wrap these muscles, I'll use red, these muscles wrap all around this joint to give it movement and stability. A bone-to-bone attachment is a ligament. A muscle-to-bone attachment is a tendon. And these tendon sheaths are tube-like bursa that actually enclose tendons to reduce friction. Imagine all of those tendons wrapping around a highly movable joint. Those tendons are going to rub across processes on bones. They're going to rub across crests and sharp places on bones, and they would wear out very quickly if not for protection by these tendon sheaths. They're fluid filled, just like bursa. Imagine this. If a tendon is a hot dog, the bun that wraps around the hot dog would be a tendon sheath. It's a protective device that allows a smooth articulation, movement of that tendon in a very bony, dangerous area. All right. Just going to talk about for a short time, a few factors influencing the stability of synovial joints. With synovial joints, always remember this: the more freely movable the joint is, the less stable it is. That's the trade-off. So first, not really sure why they list this one in your book. Articular surfaces, that means of the bone themselves. The shape of those surfaces, they help dictate the movement of the joint, but they do very little to actually influence the stability. So I'm just going to put not a great factor in stabilizing. So what we mean by that is the head of the humerus, for example, is a sphere, is a circle. The glenoid cavity is this small depression that it articulates with. This sphere riding on, it's like a golf ball on a golf tee. It can turn 360 degrees and still ride on this surface. Great for mobility. So the articular surface enhances mobility, but is not a great factor in stabilization. The next factor, ligaments, are much more of a stabilizing factor. Tough, fibrous, dense connective tissue really stabilize joints. Back to my knee picture. Let's go back here. What I originally drew in red here were ligaments that really help stabilize the knee joint, even though it's not the most stable joint in the human body. And there are ligaments not just running where I've drawn. There are smaller ligaments in here connecting bone to bone, and they have an S twisting shape to allow the knee to be able to turn. They go in a sort of diagonal pattern like this. So there's all sorts of ligaments. There's cruciate ligaments, medial and lateral, anterior, posterior. Those really help stabilize that joint. And finally, muscle tone. Most people don't know this, but the muscles surrounding the joint are actually the greatest stabilizing factor, which is why physical therapy really works in most cases, not all. The condition of the muscles surrounding a synovial joint have the greatest stabilizing factor for that joint. I'm not saying if you have knee pain, it's guaranteed that pain will go away if you undergo physical therapy. But the stronger the muscles are around any joint, the stronger the joint will be. It has the greatest stabilizing factor. We'll see how many of these move. This is a new topic now. Movements of synovial joints. I don't have time to write out every single bit about these movements. I can write out the names and I'll describe to you verbally what they mean. There's also, that's the greatest movement of joints is obviously with synovial joints, and there's different types of angular movement that's described by certain movements are common to certain types of joints as well. So the terms uniaxial, biaxial, triaxial, multi-axial, that means the movement within an axis of the bone. Axis meaning a straight line. So within an axis, bones either can move within a single axis, which would be uniaxial, or if they can sort of rotate and move along other axes in a three-dimensional space, we call those biaxial or triaxial. So that's just a bit of language. Now I'm going to go through these types of movements. Gliding movements. Just like the name says, it means sort of a back and forth. If I have two bones sitting here, it means back and forth movement across the surface of these two bones, sort of sliding. Now, more angular movements would be, I'm going to write flexion and extension in the same line, because these are opposing opposite movements. I'll give you a verbal definition of them, and then I'll explain to you what they mean. We basically know what it means when we flex our forearm or we flex our arms. The definition of flexion is just the reduction of angle at a joint, usually within one axis. So, and it's usually at a hinge joint, by the way. So flexion just means this. If I do a demonstration for you visually, I'm going to lose my whiteboard. But if we take our arm, here's the elbow, here's the forearm, and let's just say we make a fist with it. So here's a fist, and we flex it. So it's 180 degrees, your arm, when you hold it out straight. When you flex, you reduce that angle. There's the fist. You reduce that angle to 90 degrees. If you flex further, you reduce that angle to 45 degrees. So flexion and extension is just the opposite. Extension is increasing the angle, typically at a hinge joint. Next two on your list are abduction and adduction. if we have time at the end of this, I can do visual demonstrations, but I think you get the idea. Abduction, ABD, spelled ABDUCTION. This means moving away from the midline. So if you are standing up straight with your arms down at your sides, and then you raise your arms straight out to the side, that would be a movement of abduction, moving your arms away from the midline. Adduction, ADD, is the opposite. That's putting your arms down from a raised position. That's moving toward the midline of the body. You can do that with your legs too. If you're standing there and then you put all your weight on one leg and lift, say, your right leg out to the side, that's abduction. And then when you bring it back to your foot to the ground, that would be adduction, going toward the midline. Circumduction and rotation. So I'll write those on the next board. Circumduction. Literally, it means scribing a cone in space with a limb. So let's just say, I'll go through these visually at the end. So I'm just going to write cone in space. What does that mean? Well, if you stick your arm out straight, you keep your elbow straight, and you move your arm, keeping it straight just at the shoulder, and you scribe a circle with your hand, a big circle in space, what you're doing is you're scribing a cone in space. You're circumducting at that ball and socket joint. That's where this happens. That's different from rotation. Rotation is keeping the limb or the joint on one axis. So I'm going to say turning on single axis. Let me show you something really fast. So circumduction is if I take, push my iPod back. If I take my arm and I do this, I'm scribing a huge cone in space with the point of the cone being my shoulder and my fist being the large circle. Rotating my arm is different. Rotating is keeping my whole arm in the same axis and just turning it this way. So that's the difference. This is rotating. This is circumduction. Also, again, at ball and socket joints, it's very common movement. We can rotate our heads this way. That I'm keeping my head on this axis where my cervical vertebrae are. So that's rotation. We can't rotate our fingers on an axis, but we can circumduct our fingers like this. So that's the difference between those two movements. I'm just going in the order of your book. Supination and pronation. These are special movements. Supination, pronation occurs only with the hands. Supination, let me write that, means turning the palms upward. So if you hold your arms straight out in front of you and you turn your palms, both palms to the ceiling, you are supinating both of your hands. Pronation is turning the palms downward toward the floor. Dorsiflexion and plantar flexion refer to special movements at the foot. Dorsiflexion would be hold your leg out straight and pull your toes up towards your face. That's dorsiflexion. Plantar flexion is the opposite. Pointing your toes or standing on your toes is plantar flexion. Inversion and eversion are also special foot movements. Inversion just means when you are standing on the floor and lift one foot off the floor, barely, and try to turn the sole of your foot in toward the midline of your body. That's inversion. Eversion is turning the sole of your foot out laterally. So I'm not going to show you my feet, but if my hands right here were my feet, inversion would be if I turn the soles of my feet inward toward the midline. Eversion would be if I turn the soles outward this way. Protraction and retraction. Protraction means moving something forward. So this is a common movement that's accomplished at the lower jaw, the mandible. So if you jut your jaw forward, pushing it forward, that's protraction. Retraction is simply pulling it back. You can protract your shoulders too. So if I, not shrugging your shoulders, don't lift them up, but if you point them forward anteriorly, that's protraction, and then pulling them backwards toward your shoulder blades is retraction. Elevation and depression, we're almost finished here. Elevation means moving upward, just like an elevator. Depression means moving downward. So once again, at the mandible, my lower jaw, just closing the lower jaw is an elevation move. It's raising that mandible. Opening your mouth would be a depression move. That's lowering that jaw. These two moves can also be done at the shoulders. If you shrug your shoulders, you lift your shoulders up, that's elevation. When you let them go back down, that's a depression move. Technically, what we say in that case, when we shrug our shoulders, it's the scapula on the back. If you put your hands or your fingers on somebody's back and tell them to shrug their shoulders, you'll feel both scapula move straight up. That's an elevation move. And a depression is once they relax their shoulders, those shoulder blades drop down. That's a depression move. Finally, the last move, opposition. This is a special primate maneuver that we do with our hands, and it's the thumbs crossing over the palms. So just sit there and look at the palm of your hand, kind of spread your fingers apart and your thumb out. Now take your thumb and cross it over your palm to touch your pinky. That's something we take for granted, that opposing movement, it's called opposition, is very rare in the animal kingdom. That allows us to manipulate all sorts of things in our hands as well. I think I'm going to call it good there. So let me stop my recording and then I'll say a few things and take questions.